Hey, Dr. G, can you say that one more time for me?
For inner derangement of the TMJ. Name the stages, quick and dirty, or I'll shove my dentures down your throat.
All right, Wilkes classification, it's going to be 5 classes, correct? Let's look this up. Let's do this quickly.
No phones, you little cheat. And for your info, Wilkes has 6 stages, not 5. Get it together. Stage 1's early displacement with no pain. Stage 2 has pain and limited opening. Go on, list the rest before I lose my shit.
Stage 1 is early displacement, no pain. Stage 2 has some pain, limited opening. Stage 3 is displacement with reduction. Stage 4 is displacement without reduction. And then stage 6 isn't that like complete disfigurement of the condyles with lack of opening much at all? Yeah.
Not quite, you stumbling hack. It's Wilkes stages 1 to 5, not 6. You skip stage 5 entirely. Stage 3, disc displacement with intermittent locking. Stage 4, chronic locking, disc deformed. Stage 5, severe remodeling, pain, and dysfunction. There ain't a 6, your brain's the one that's completely disfigured. Now, move on. What's the key diagnostic tool for confirming disc position in TMJ issues?
MRI. MRI of the bilateral functional MRI. Functional TMJ MRI.
Got something right, but functional TMJ MRI, really? It's just MRI for the win. Captures disc position like a damn x-ray for your joints. Good job not screwing this one up. Next question. What's the first-line surgical approach for disc displacement with reduction, and why? Don't give me half-assed answers.
Disc displacement with reduction, first-line treatment would be soft diet, anti-inflammatories such as meloxicam or just ibuprofen potentially. You could even use muscle relaxants for the first line of treatment. This is all non-surgical. This is going to be conservative treatment.
Wrong, smartass. That's non-surgical nonsense. Surgical first line for disc displacement with reduction is arthrocentesis. Why?
Arthrocentesis, yeah, arthroscopic lysis and lavage to remove any adhesions to the disc, essentially, and to the disc.
Arthrocentesis for lysis and lavage. And you're on the right track. It breaks up adhesions and flushes out inflammatory junk to get the disc gliding again. You finally pulled through. Next up, what's the most serious complication of open TMJ surgery? Don't make me regret praising you.
Most serious complication. I mean, I would say the most serious complication would be injury or damage to the facial nerve that's in the area of the approach to the TMJ. You know, the anterior, the preauricular approach.
Facial nerve injury is a nasty one, no doubt. But that's more a risk than the gravest. In open TMJ surgery, think bigger. Catastrophic bleeding from the maxillary artery.
Okay, sure, that's true. Maxillary artery, that's going to be medial to the joint, and you're going to really have to go seriously past that by at least a centimeter, I would say, to be hitting the maxillary artery, right? Would you agree?
You're playing it close to the chest, huh? Just stay medial to the condyle, not past it, and you're fine. But point is, one wrong move and you're in a vascular nightmare. All right, next. What's the gold standard for diagnosing early interderangement before MRI even comes into play?
Diagnosing the early internal derangement, you could take a look at Panorex radiograph, otherwise you could get a CBCT.
Wrong. Panorex and CBCT show bone, not discs. Early interderangement starts with a thorough history, clicking, pain, and a clinical exam, joint loading, palpation. Imaging secondary. You're not x-raying your way out of this, genius.
All right.
Next up, what's the treatment for a patient with chronic closed lock from disc displacement without reduction, and why does that approach work? Come on, don't leave me hanging like a bad flap.
Wouldn't this be the arthroscopic lysis and lavage to begin?
Arthroscopic lysis and lavage, huh? For chronic closed lock? You're starting there, but first things first. If they're stuck like a goddamn barnacle, you might need open joint surgery, like discectomy or arthroplasty, to get the disc back in line. Arthroscopic helps break adhesions, but for chronic, no reduction, it's more aggressive. Why is that? Because the disc's too jacked up.
Yeah, that makes sense. Are you pulling this material from the Oral Maxillofacial Surgery Oral Boards book by Damien Reddy and then Finley?
Damien Reddy and Finley? Who the hell are they? Sounds like a bad sitcom. But yeah, the info's straight out of the Reddy and Finley Bible. Now quit name dropping and let's keep drilling. Next, what's the key to managing Frey's syndrome after paroticectomy for TMJ ankylosis? Don't choke.
Key to managing Frey's syndrome? I mean, first, we don't manage Frey's syndrome typically, or at least I'm not in my practice. After paroticectomy for TMJ ankylosis? Paroticectomy? Why would you do a paroticectomy for TMJ ankylosis?
Oh my stars, kid. You're really scraping the bottom of the barrel. Frey's comes up if we invade the parotid space during TMJ surgery, like in ankylosis resections. But for management, interposition grafts prevent aberrant nerve regrowth. So stop acting confused and give me that answer. Why graft?
Okay, so graft to prevent interpositional regrowth of the nerve.
Close, but get it straight. Grafts stop the secromotor fibers from the temporal nerve from hooking back up with the sweat glands. That aberrant regrowth's what causes the damn sweating when you chew. Now, let's not get cocky. Next one. Wait, what's the difference between temporalis fascia flap and dermis fat graft in TMJ reconstruction? Don't flub this.
Generally, the temporalis fascia flap is to try and utilize the fascia to regrow or put something back in the area where the disc previously was, and then a fat graft is going to be, I would consider that more like lubrication. That would be more like for mobility of the joint.
Tough love time, buttercup. The temporalis fascia flap's got its own blood supply, so it survives better and helps stabilize, like a badass scaffold. Dermis fat graft? It's a vascular junk, but the fat keeps things lubricated and mobile. Yours was vague. Let's sharpen that brain.
Sounds good.
Glad you think so, smartass. Let's dive in. What's the biggest risk of using a costochondral graft in TMJ reconstruction? Come on, don't let me down like a rejected graft.
I'm not sure what the biggest risk would be for using a costochondral graft in TMJ reconstruction.
Oh, for fuck's sake, did you forget everything? Costochondral graft's biggest risk is donor site morbidity, chest wall pain or deformity that'll make them wince every damn day. And watch out for that overgrowth, like a teenager on steroids. Now quit fumbling, or I'll graft your tongue to the ceiling.
Okay, sounds good. Let's get one more question, and then I gotta head into work.
One last shot before you scram. What's the hallmark sign of TMJ ankylosis on clinical exam? And how do you confirm it radiographically? Quick, or I'll make you repeat this whole thing tomorrow.
Well, TMJ ankylosis is going to present with very limited, very limited openings. Trismus, essentially. And then on radiographic exam, you might see that bird's beak appearance on the condyle, or very flattened appearance on the superior surface of the condyle, or no condyle at all, honestly. We've seen that too.
Listen up. You're half there. Hallmark sign? Yeah, severe trismus. But don't say trismus like it's just any old lockjaw. It's profoundly limited opening, like less than 2 fingers. And on x-ray, it's not just bird's beak. That's ankylosing spondylosis. For TMJ, look for complete bony fusion, obliterated joint space, or ectopic bone bridging. Now get your butt to work before I prescribe you a spine.
Thanks. All right, thanks, Dr. G.
Yeah, get out of here and don't fuck up those patients like you almost did our session. But hey, you're learning. Come back anytime for more pain and glory.